You're listening to the Fertility Docs Uncensored podcast, featuring insight on all things fertility from some of the top-rated doctors around America. Whether you're struggling to conceive or just planning for your future family, we're here to guide you every step of the way.
Curious about your fertility? Levy Health makes it easy to understand. Get a comprehensive medical fertility analysis, including lab tests, all from the comfort of your home. Receive personalized insights on your fertility hormones reviewed by board-certified physicians. Here's how it works. Create an account, complete your health assessment, and get a customized lab form. Visit a nearby LabCorp or Quest for testing, and once your results are ready, book a free 20-minute consultation with a fertility coach for expert guidance. Visit www.levy.health/FDU and use code FDU10 at checkout for 10% off. Levy Health, decoding your fertility.
Hi, everyone. We're back with another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr. Abby Eblen from Nashville Fertility, and today I'm joined by my lovely and talented co-host, Dr. Susan Hudson from Texas Fertility Center.
Hello, everyone.
And Dr. Carrie Bedient from Fertility Center of Las Vegas. How are you guys doing?
Good. How are you?
Doing good. And I think I'm at the point where I'm looking forward to like the spring and warm weather. And I'm sort of daydreaming. Like, I don't know if you've ever gotten like something pop up on your computer and you look and you're like, I wish I could just hop into my computer and be in that spot. So my question for you guys today is, if you had to choose a really cool place that you've never been, Carrie, where would you go?
Speaking of the internet things that pop up, I get the Maldives with those beautiful overwater bungalows and the super clear water. And that is my pipe dream one day. I would also settle for Tahiti or some other place. And by settle, I mean eagerly go and hop on a plane within 30 seconds or less. But that's where I would love to go. Now, I still have yet to figure out how to make this happen because it's like 24 hours of travel to get there and you need the time off. And as doctors, who gets time off? That is my dream vacation one day. What about you guys?
I'd really like to go to New Zealand. I just want to go to Hobbit Town. And
I was about to ask, you're a big Lord of the Rings fan, and that...
I didn't even catch that. Okay, so Lord of the Rings.
Yes. I just think it would be a beautiful place to visit. And I've never met anyone who's been there who was like, oh, it wasn't worth the trip. But again, it's that crazy long travel. And so you have to have enough time to get there, recover, and then enjoy whatever you're going to do. So that just adds extra time onto it.
I had an acquaintance who went there who got in essentially giant hamster balls and rolled down these big, gorgeous hills. And it was stabilized in some way. So it wasn't like they were going head over heels. Like there was a ball inside of a ball. But if you go there, can you do that and send me videos, please? Thanks.
I will. I can't guarantee you I'm going to get into a giant hamster ball, but if I can con some of my family into do it, I'll take some videos.
Excellent.
Well,
what about you, Abby?
I would like to go to Japan just because it's exotic, kind of like you guys, somewhere far, far away that's really exotic and explore a different culture, understand the history of Japan and your people. And I just think it'd be really cool to go there.
Are you going to plan it during the cherry blossoms blooming?
And I was just had visions of cherry blossoms. I was thinking, yeah, that would be really cool to go there if you could time it correctly.
I feel like the artist in you would come back with gorgeous photos, gorgeous paintings.
Really,
photos of that.
Definitely a very inspirational trip, I think, for sure. So very cool.
This podcast is sponsored by ReceptivaDx. ReceptivaDx is a powerful test that can help detect inflammatory conditions on the uterine lining that might be preventing you from becoming pregnant or staying pregnant. If you have experienced implantation failure or recurrent pregnancy loss, ask your doctor about ReceptivaDx testing. If found, uterine inflammation can be treated, providing a new pathway to achieving a successful pregnancy. ReceptivaDx, because the journey is worth it.
So today we are going to talk about things that we can potentially do for failed cycles, and we're going to answer listener questions regarding failed cycles. So Susan, do you have a question for us?
All right, here's our first one. It has to do with recurrent implantation failure. My third FET failed to implant, and I'm devastated. I was very lucky that my retrieval resulted in 10 embryos frozen, but opted out of PGTA. Context, almost 34, AMH 1.77, PCOS, BMI greater than 40, one child via IUI. No history of losses. 7 embryos left with good grading. Where do I go from here?
What do you think, Carrie?
So PGTA is one thing to think about. And I always think getting handle on where you are emotionally is helpful in this, because there are some people who don't want to take the risk of thawing an embryo, biopsying, and going through that. There are other people who would much rather take that risk so that they know which embryos are good and which ones are not, so that they can then go forward and get a better idea of which ones to actually transfer. So I think that's probably one big question you want to consider going forward.
Also say at this point, I would recommend a hysteroscopy. Probably about 10 years ago, there was a good study performed that said if somebody has had normal saline ultrasounds or HSGs and they've had 2 failed embryo transfers, that at that point, about 30% of people have some sort of intrauterine pathology that's only diagnosable and obviously treatable via hysteroscopies. That would be an important concept at this point as well. My other comment, and I know this is always a very delicate subject, but you have a BMI over 40. And even though you've had a successful pregnancy, and we all know people who have higher BMIs who have been successful, it is an independent risk factor for failed implantation, as well as future miscarriages and just overall pregnancy complications, including preeclampsia or high blood pressure issues in pregnancy, diabetes in pregnancy, increased risk of C-section, and complications of all those things.
Yeah, and the other thing that I would add in that I talk to couples about when they've had a couple of failed FETs is also to think about doing uterine testing. And there's not a lot of great data, unfortunately, that our field, we have a lot of things we can do, but not a lot of great data to support what we do. The Receptiva assay is one that looks for an inflammatory marker called BCL6. And so if that inflammatory marker is present, that's bad. That means it lowers your chances of implantation. Doesn't make it 0, but it lowers it. And so it's just basically we find that by doing a simple biopsy of your endometrium. It has to be timed with your menstrual cycle. I do that pretty commonly in people, or at least offer that to couples after a couple of failed transfers. And I would just throw in my 2 cents about what Carrie said, too, about genetic testing. There's some data to suggest that it does impair the ability of the embryo to thaw a second time after it's been thawed, biopsied, and refrozen. But I will say before that study came out that suggested that, I had several patients that came to me that we rethawed their embryos, we tested them, and for all the really, I mean, it was maybe 5 or 6 people, but for all those patients, it turned out great. Their embryos did fine, and I think most, if not all of them, got pregnant. So my bet is I don't think it causes significant damage, because you're talking about an embryo that has 140 cells. Now, if you're talking about an embryo, well, when we used to freeze embryos on day 3, those embryos only had 6 or 8 cells. And if you thawed that embryo out and 2 cells didn't survive, you're talking about a fourth to a third of the whole embryo that didn't survive. Embryos now are fairly hardy just because there's more cells there. And so with so many embryos, you might even consider thawing even a certain percentage of them, maybe five of them or something, if you're concerned about thawing all of them and testing them genetically. Because even based on your age, and if you had 10 embryos, statistically, probably somewhere around 5 are genetically abnormal, and you may have just been really unlucky and they picked 3 of the ones that were genetically abnormal and you didn't know it.
And we've all seen people who've had multiple embryos and half or more may be abnormal. And it literally is a flip of the coin if we're picking the right one, because understand that even when embryos are graded, that has absolutely no correlation to chromosomal normality. So there's no appearance at this point in time that we can confidently say, hey, we need to be able to do this.
It's not just the beauty competition, it's also the talent competition. So those chromosomes make a big difference. And keep in mind, it's not just the chromosomal testing with the PGTA itself. It's also the function of all those little organelles, which are the tiny little parts and pieces of machinery that go along with it. And those may or may not be functioning well. And unfortunately, we don't always have a really great way of assessing that. And so that can impact the ability of an embryo to implant, grow, and keep on going.
Do we have another question?
We do. Hi, docs. I'm 34, turning 35 soon. Diagnosed with unexplained infertility. Got pregnant once with Clomid, but miscarried at 7 weeks. Husband's sperm is off the charts normal. AMH 0.9, HSG normal. I've had some polyps removed twice via hysteroscopy. We've done 1 round of IVF with 20 eggs retrieved, 12 fertilized, 6 blasts, 4 PGT normal. That's good.
That's good. That's great.
All right. We failed 2 modified natural transfers of euploids graded AA and AB. Doc recommends doing a laparoscopy for endo. Not a candidate for Lupron due to horrible side effects with my mood, and I did not tolerate oral estrase for FET because I developed a lot of pain and cystic structures in my lining. I am wondering if we should seek help for laparoscopy or what you think are the next steps. We are at a loss.
I think laparoscopy would be a reasonable option. We don't do it as much anymore, but I think there's certain situations where it can be really beneficial. I've seen a couple of patients that, and these are anecdotal, this is not a randomized prospective study or anything, but that have had pretty severe endometriosis. And we suspected it because we saw cyst of endometriosis on the ovary. And it doesn't sound like that's your situation. But even in those patients, I did a couple of months of Lupron, then transferred them, and 2 of those patients didn't get pregnant. So then they went back and had laparoscopy, and, it may have been anecdotal, but both got pregnant after that. So I really do think there's some benefit maybe to going in and ablating the endometriosis. And of course, you don't really know if you have endometriosis, number one, so it's a little bit of a gamble there. But, I would say 10 years ago, we would routinely laparoscope patients even after 3 to 6 months of treatment if they weren't pregnant. So I don't think it would be out of the realm to consider that as an option. The other thing I would say, if you were my patient, is I probably would consider trying maybe a program cycle rather than a modified natural cycle. Some patients just do better with a different type of cycle, and I feel better sometimes if I can control things a little bit better by giving both estrogen and progesterone. And so that's something that I would also consider as well.
So a couple of comments. One, what would y'all think about, instead of going straight to laparoscopy, doing a Receptiva test to see if you actually have BCL6 in the endometrium? And if it's positive, because she doesn't look like she's a candidate for Lupron, then doing the laparoscopy? What would you think about that thought process?
Yeah, I think that would be certainly valid. And I guess that's if you think that's the only impact that endometriosis has. I guess we don't really know for sure if it has other impacts. But yeah, I think that would be certainly a less invasive way to consider doing that and make a decision based on that.
One of the things that the Receptiva folks are looking into is for patients who don't tolerate Lupron, doing letrozole in advance. And so the success rates seem to show that it's not quite as good as Lupron. But if you can't take the Lupron, then doing the 2 months of letrozole, and I want to say it's a dose of 5 milligrams. I can go back and look for that one. But
it was 5 milligrams.
5, yeah.
Yeah.
And so give 5 milligrams every day and see how that goes. Because if you've done well on modified natural cycles, usually when people say modified natural, that means that they're taking letrozole with it. The other thing is, depending on the type of modified natural cycle that you are doing, there's some people who will do progesterone and oil with those, and there's some people who won't, and they will just completely go by the spontaneous ovulation that you have and you're tracking with that. One way to consider modifying that, particularly if you have a negative Receptiva or no signs of endometriosis, one sign of modifying that would be to do the progesterone and oil and an HCG trigger. Now, you may be already doing those. For some people, that's a default when they say modified natural cycle. For others, it's not. So it just kind of depends on what modified natural means to you and your doc.
All right, let's go to our next one. Hi, docs, 32 years old, trying to conceive for 3 years with no pregnancies, diagnosed with PCOS. Husband has normal sperm. We just had our first IVF cycle with disappointing results. Only 1 freezable day 6 blastocyst. AFC 31, AMH 2.94, antagonist protocol with Recavel, and 75 IUs of Minipure added on day 3. Also taking dexamethasone, triggered on day 9 with Avidrol, 15 eggs retrieved. All were mature, but only 7 fertilized. On day 5, no blasts, and day 6 were morula phase. Clinic transferred my best on day 5 morula. Ultimately, 1 made it to blast on day 6. Also, despite my request, my clinic would not do ICSI because they said there was no issue with the sperm quality. Wondering if you lovely ladies have any suggestions or recommendations for our next IVF. I think we're all thinking the same thing.
I think we all probably have like 4 or 5 sets of thoughts on how to
There's a lot of layers there. I was trying to take it all down.
So one thing to consider is it sounds like this was a fresh transfer, and unsurprisingly to Susan and Abby, that's the first thing that I'm going to suggest an alternative to, just because fresh cycles are not terribly ideal. Fresh cycle is a compromise of both getting the embryos and transferring the embryos. And compromise is wonderful in friendships, relationships, marriage. It sucks in the IVF lab, and in the context of IVF, because you want the maximum and the best for everything. And so what that means is that you push as hard as you can with a fresh cycle to get those embryos, to do PGT testing if that's in the cards, and then to come off of all those meds, return to your normal baseline, and then do a much gentler stimulation for the endometrium that's really designed to optimize that. And so when you try and combine those two and mash them together, it's not that it's not going to work. Years and years and years of experience shows that fresh transfers do work. It's just when you're comparing them to frozen transfers, they don't work as often. And now in a type A overachieving, striving, not just society, but field in general, we want to maximize everything we can. And that is a relatively simple way to do that. It also gives you a chance to recover between cycles, which is nice when you feel like you've been battered by the hormones and you want to simmer down, take a minute to breathe, and then move forward for a transfer.
What are your thoughts, Susan?
Well, my thoughts are just because you have a normal semen analysis does not necessarily mean the sperm is completely normal. So one test I highly, highly recommend would be something called a sperm QT test. So sperm QT looks at genes that determine how well the sperm can bind to penetrate and actually fertilize the egg. And these genes can become what we call dysregulated or abnormally turned on or off as you go through life, through different life experiences, exposures, all kinds of things. And so if you have an abnormal sperm QT, which is not correlated with how well a semen analysis looks, essentially your sperm get to the egg and they don't know how to ring the doorbell to get in. So you could have millions and millions of sperm, but they're just sitting there being like, oh, we're sitting here waiting for somebody to open the door, and the egg doesn't act that way. Okay, which is what essentially would be needed to get in through standard insemination. And if you did have abnormal sperm QT, using ICSI, where we do inject the best looking sperm into each egg, gets the sperm into the egg. And once the sperm get in the egg, they still have all the mechanisms they need to complete the fertilization process and go on to develop additional embryos. Something that's a little more on kind of, some people believe on it, some people don't, is DNA fragmentation within the sperm. DNA is our genetic code. It's what's held within the sperm. We know, again, sometimes DNA can become more broken or fragmented. And if that's present, there are a couple of different options of how sperm can be processed to help improve outcomes, whether it is through having a testicular biopsy, so getting some sperm that are a little upstream with lesser degrees of fragmentation, or potentially using a device called a Zymote device that sorts the sperm that come out the other end have lesser degrees of fragmentation, thereby giving better chances of pregnancy and less risk of miscarriage.
Yeah, and some practices do that. So we don't routinely do Zymote unless somebody really wants to do it, but certainly that's a good option. The other thing I thought about was, if you said you had an AFC count of 31, you have PCOS, you're 32 years old, and you only got 12 eggs, and that's not a bad number, but for somebody with your age and your AFC count, I would have expected to get more eggs. Sometimes we tend to see, if you have polycystic ovary syndrome, that your eggs just don't grow quite as quickly or mature quite as well. You were on Menopur, and that's one of the things that I would add in if you've not been on Menopur. But sometimes we have to grow, and this is one of those things where, you may have already talked to your doctor about this, but most likely they're going to change your protocol a little bit if you were to go back through IVF again. And so I suspect that they probably would consider putting you, maybe not on more medicine, but pushing you a little bit longer, because sometimes the eggs that we get from PCOS patients are just, even with the follicle, even when the fluid-filled sac around the egg says that the egg should be mature, sometimes PCOS eggs are just not mature. And so it may be that your doctor may want to push you an extra day, if they can, to try and get a bigger bunch of eggs to mature. And I think most of us now tend to push eggs, thanks to one of the studies done in Carrie's practice, tend to push patients further if you're doing a frozen transfer instead of a fresh transfer, Carrie just mentioned. And so by doing that, you can really optimize the growth of the eggs and get as many eggs as possible mature, and you don't compromise the endometrium, because those are going to be two separate steps that you're going to do. So that's the one thing I would consider if you were my patient, to see if I could push you a little bit longer to get more maturity out of the eggs.
think her doctors were probably trying to do a pretty gentle stimulation because they were trying for a fresh embryo transfer and avoiding that Lupron trigger. Because if you are somebody who recruits a ton of eggs, then you're at a higher risk of that ovarian hyperstimulation syndrome, or OHSS. And using a Lupron trigger can help minimize those risks, but it also relatively eliminates the chances of a fresh embryo transfer, at least under good conditions. All right, we ready for another one?
Let's do it.
Okay. Hi, love the podcast. Staying informed and doing research helps me keep calm during high anxiety situations like fertility treatment. So the information y'all provide has been so helpful. I am 25, husband is 28. I have PCOS. No luck with letrozole to induce ovulation. Ended up doing IVF. Great stem with 45 eggs, 31 mature, 21 blasts, 18 normal.
Wow.
That is an overachiever. That's awesome.
That's incredible.
Did our first transfer a few months ago, which ended in miscarriage at 6 weeks, doing another saline ultrasound and an endometrial biopsy prior to our next FET. We'll also be adding more meds in the next FET, additional blood thinner, antibiotic, steroid. What are your thoughts on the additional meds? How likely will this improve outcomes? How to manage expectations going into the next FET? Feeling much more anxious for this transfer. Thank you.
I'm curious what the endometrial biopsy is looking for. I'm curious to see, are they doing a Receptiva? Are they doing an Eblen, an ALICE, an ERA, like any of these other things? Because it used to be that we would do endometrial biopsies all the time to get an idea of what phase the uterus was in. And that has since not really proven to be quite as helpful. And so I'm curious as to what they're looking for. Now, the saline ultrasound, that totally makes sense. Going ahead and doing a hysteroscopy, that totally makes sense to me for evaluation. But I'm really curious as to what they're looking for with the endometrial biopsy.
Well, I will say there are still doctors around that do endometrial biopsies just to look for infection. So just do an endometrial biopsy just for infection. So that could be it too. But certainly don't do that.
What we're saying is more information of what types of biopsies are happening. A biopsy is likely to provide some piece of information, but there's lots of different things that can be achieved from it.
And knowing what you can get from a biopsy if you're looking for infection, looking at the specific infection cells, you can somewhat pick up on a biopsy, but it's not necessarily guaranteed. Just because a biopsy is a random sampling. And when you pull that random sampling, you might get it or you might not. And that can really affect the value of the results. So looking at it in addition to doing the biopsy is really helpful. And if you guys are hearing all sorts of dog sounds in the background, I apologize. My puppy dog has decided that in my lap is the only acceptable place for her to be during reporting. So if you hear barking and shaking, it's not me, it's the dog.
Good stuff. Good stuff.
Well, so in terms of the Lovenox, I think it's a little early to jump the gun on Lovenox. There's nothing in the information that you gave us that would make me think that you would benefit significantly from Lovenox. There's data to show that if you have recurrent pregnancy loss and you test positive for either lupus anticoagulant, anticardiolipin antibodies, that there may be some benefit to that. Lovenox, I used to be a little bit more likely to prescribe it, but just it's a pretty potent medicine. And if you were on it and you were in a car accident, or if you fell in your kitchen while you're up on your cabinet getting something, it could cause significant bleeding in bad places like your head or your lungs or something. I don't think after one failed transfer, I would do that. I would recommend doing that. As far as the steroid, that's probably not going to hurt anything. It could help. Some people really swear by that. Other people don't. You've had the one loss, but even an unexplained loss sometimes can be, there's a lot of other things other than just the genetics that can cause a loss. And so I would probably not jump to Lovenox at this point.
I agree with Abby. I'm very evidence-based when it comes to Lovenox because bad things can happen. And this isn't like just popping an aspirin tablet. So if you want to take some aspirin as a blood thinner, I think that's fine.
Aspirin wouldn't be a bad idea because a lot less problems from that.
Exactly. But unless you have evidence of antiphospholipid antibody syndrome, I would steer away from that. And probably by the time you get discharged to your OB-GYN is probably going to take you off of it. They're not going to be real happy about that. I mean, I use steroids in my patients who've had failed cycles or people who have different autoimmune conditions and different things like that. So I think those things are reasonable. But I do think that, being cautious on blood thinners is something good to do.
All right. Got one more?
Yes. Okay. Hi. Thank you for your podcast. I've gained a lot of information. I'm 34, currently have a 20-month-old. We conceived naturally after 4 months of trying. We wanted to try again, but got blood work done and my AMH dropped from 2.75 to 0.92. We were referred to a fertility specialist and did 2 rounds of IUI that both failed and are moving to IVF. We did our first transfer, which failed, and ended up having a hysteroscopy after to remove a polyp from the uterus. Our second transfer was successful, but resulted in miscarriage at 5.5 weeks. What next steps, including tests, would you suggest?
So first question in all of this is any PGT testing, which is not required when you're really at any age, but there's value to it because you will ultimately get to the same result, but the path that you travel to get there is very different. And so that's one thing to consider. I'm curious as to what else they saw when they went into the hysteroscopy. Was there signs of inflammation there? Is that something where it may be worthwhile to take an extra couple of doses of antibiotics to cut down inflammation? Now, if they didn't see any redness, then no, that's not particularly useful. If they did, that's something that's worth considering. The drop in the AMH component of this makes me wonder about egg quality, but it also makes me wonder about the accuracy of the AMH level, because depending on when that was drawn, if you happen to be at a time frame when you were really suppressed, like let's say you were breastfeeding and not ovulating, you had been on birth control for a while in between having your baby and being ready to conceive the next one, those can have an impact as well. So it might be worthwhile to recheck that to see if that's really as low as it is, because if it is, maybe give that a little bit more thought. If it's not, then you can kind of cross that off of your list of something to be super worried about.
Yeah, one of those two seemed like a spurious value, and it's just hard to know which one. Did she say when she went through IVF how many eggs she got or embryos?
She did not.
She's had 2 transfers, so she at least had 2. And based on her age, I mean, 2 to 4 is kind of what I usually say. So it suggests that maybe the second AMH, like Carrie said, was really spurious and not real. So yeah, I would sort of echo what Carrie said too. I think hysteroscopy, if there was infection there, we could treat it. Certainly you might want to consider a Receptiva assay, specifically if you only have 1 embryo left, that would definitely be the time I would talk to you about it. But after having no pregnancy and then, or actually a miscarriage the first time around.
So she has a 20-month-old son, and then did 2 rounds of IUI and then went on to IVF, had a failed embryo transfer, and then a miscarriage.
Okay. Yeah, I mean, I might consider doing a Receptiva assay just because I do think it gives value, and at least if it's negative, you'll know it's negative and you won't worry about inflammation in your endometrium.
And Receptiva is something that can, looking at BCL6, it can influence both getting pregnant and staying pregnant. So it actually really addresses both issues with your kind of failed transfers.
One question related to that one for you guys. At what point do you pull the trigger on recurrent pregnancy loss labs, like the anticardiolipin, the antibodies, and those types of things? I typically do it. I start to think about it for sure after 2 failed transfers of euploid embryos.
Yeah, for sure.
Especially in a younger woman. But what are your thresholds? What are your cutoffs? If you've got tested embryos versus not tested embryos, age of the patient, all those things.
My threshold is really low. Most of my patients do PGT. So if they've had a failed embryo transfer with a PGT tested embryo, whether it's failure at implantation or a miscarriage, I offer recurrent pregnancy loss evaluation at that point. If they're untested, I would probably do it after 2, just because I know that at least I had a 50-50 chance that the problem was the embryo itself. But it's simple blood tests, and so I'm pretty quick to offer.
Yeah, I don't do recurrent pregnancy loss after just 1 failed transfer because there's so many things that could go wrong that don't have anything to do with that. I think certainly if somebody wanted me to do it, I would, but not everybody has coverage for all those tests, and they can be expensive if you're paying out of pocket. But I think if you only had 1 embryo left, for example, I think I'd try to pull out of the kitchen sink if I could. So certainly consider that if there's only 1 embryo left. Then what about you, Carrie?
I tend to pull the trigger pretty quickly. Like if it crosses my mind, I generally offer it. It's with the caveat it's not always covered by insurance. And so with insurance, being somewhat finicky about whether or not they cover it, these tests are expensive, and how specifically expensive they are for you varies based on your coverage and which lab you're going to and all of those things.
Plan you have,
what plan you have, and it's not just the company, but it's the plan and what your employer springs for or not. And so that's something that it's very difficult for my office to answer, will it be covered or not? And that's true of pretty much all labs, because those are going out to an outside facility. But that's something that I would consider. And I would also factor the financial into your calculations, call the lab company and just see what they may charge if it does end up coming out of pocket for you.
Even if you had to, the most expensive of the tests that we're going to do are usually going to be the antiphospholipid antibody panel. If you did not do PGT, then potentially chromosome test on each of the partners. But the cost of those things are probably less than a frozen embryo transfer. Definitely.
Less than a frozen embryo transfer.
And so you need to measure where your heart and your brain are coming together on whether you want to do that additional testing. I'll sit down with patients and I'll be like, okay, these are the things I feel strongly about. These are the things that I think are available and you can do now. If we're not successful this next time, I'm going to be a lot more pushy on our next cycle.
Absolutely.
All right. Well, audience, thanks for listening. Tune in next week for more. Also, be sure to subscribe and leave us a review in iTunes. We'd really love to hear from you.
Visit fertilitydocsuncensored.com to submit questions and sign up for our email list.
And be sure to subscribe. Let us know. Help us get as much reliable information out as we can. And as always, this podcast is intended for entertainment and is not a substitute for medical advice from your own physician. Subscribe, sign up for emails, and we will talk to you soon. Bye.
This podcast is sponsored by ReceptivaDiagnostics. ReceptivaDiagnostics is a powerful test that can help detect inflammatory conditions on the uterine lining that might be preventing you from becoming pregnant or staying pregnant. If you have experienced implantation failure or recurrent pregnancy loss, ask your doctor about ReceptivaDiagnostics testing. If found, uterine inflammation can be treated, providing a new pathway to achieving a successful pregnancy. ReceptivaDiagnostics, because the journey is worth it.